Okay, good afternoon, everyone. I will be briefly taking you through the previous experiences and outcomes of our program. So we started this program in the year 2018 with CME with a difference in coordination with the Kanpur Ophthalmic Society. Briefly after that, it was presented for the first time in the state level in the Uttarakhand State Ophthalmic Society. After that, a small exercise was conducted among the postgraduate students. Yeah. So after that, a short exercise was conducted among the postgraduate students of GSVM Medical College Kanpur. And after the success of it, we, for the first time, presented this entire program at a national level. And we have been doing that since the year 2020 at Gurugram, Mumbai, and even in the virtual AIOC. And currently we are presenting its next version here at Kochi. So between these times, we have also conducted various online surveys about which I'll be telling in the further slides. So how it all began. So there was a reality check that is artificial intelligence an accessible possibility in the setting of our country. And there was evaluation for need of artificial intelligence for the purpose of identification of treatable DR. That whether we actually need AI or could this be done by even human resources. So we needed to teach ophthalmologists the identification of treatable DR, and we needed to simplify this procedure of identification so that referral could be done. So we need to look in the future and we need to make some decisions. For that, in the very beginning, we need to identify what should be the referral threshold for each and every ophthalmologist. And we need to standardize this entire concept and therefore present it at a mass level. So in the year 2020 at AIOC conducted in Gurugram, for the first time we presented it at a national level and where we introduced the basic features of diabetic retinopathy. After that, we gave voting pads to the audience and conducted an on-spot voting. So the goal was to conduct an interactive session and obtain a live analysis from it. So the basis of the course was basically a vision-threatening diabetic retinopathy features. These were chosen. And to simplify the entire criteria, we used the ICO guidelines, and the basis was diabetic macular edema involving center or not, rather than CSME. So the training was done in two steps. In the first step, they were shown simplified photographs of DR, and the voting was conducted. And the response of the entire audience was recorded. A random selection of strata was done so as to mandate any sort of participation. So this was the sample slide. We just showed the slide for 30 seconds and asked the audience that, is this vision-threatening diabetic retinopathy? Everyone was given 3 responses, yes, no, or cannot be commented upon, and then the voting was conducted. So this was an example of a response which was recorded where around 54% people said that, yes, this is vision VTDR, and there were 25% with no and 21% who said that this cannot be commented upon. So the responses after showing around 10 to 15 slides were erratic in nature, and there was a state of uncertainty and doubt. So after this, we introduced the basic criteria of ICO. Then we again showed some pictures of disease patterns like macular edema, vitreous hemorrhage, NVD, NV, etc. Again, we showed the VTDR characteristics, and the entire process of voting was recorded once again. After this, after the second round of voting, we saw that there was a very predictable outcome. The mandate was pretty clear in the clear cases, and hence we needed to upgrade the decision-making capacity of all the ophthalmologists. But there was a moderate sensitivity in the borderline cases, so we needed to work on that. So VTDR was definitely a reference threshold after this entire session, and the target audience was non-retina ophthalmologists. The limitations of EI were also demystified, and the objective and scope of human analog was better identified. After this, we conducted few online surveys in May 2021 and in November 2022. Responses of 23 and 58 participants respectively were recorded. So before recording the online survey, we showed them 2 slides where we showed the VTDR characteristics. And in the above slide, we showed them about the 4-2-1 rule also. And below we showed that what are the different features of vision threatening diabetic retinopathy. After that, we conducted such an online survey where again we showed the images of diabetic retinopathy and gave them 3 responses: yes, no, or can't say. So this was the responses that were recorded in both the online surveys. So after recording such responses, again we could say that the mandate was pretty clear in all the clear-cut cases. This was the latest random online survey which was conducted in March 2023, and for the first time we recorded a response of 100 ophthalmologists which were all randomly selected. And a similar response was recorded as before, but on a larger scale. So these were the answers when compared from the 2020 to 2022 sessions. So we can see that the correct answers are 60% and 70%, which is expected after teaching them something. But there was still something which was wrong answers were 20% in the year 2020, which we tried to improve in 2022 after even educating more. So the wrong answers came down to 0%. But still there are around 20 to 30% population who cannot decide that whether this is referable case or not. And now we think that VTDR is the thing which is creating some confusion. So in order to resolve this confusion, we think that MTMDR, which is more than mild diabetic retinopathy, is a better option than VTDR. So if you find something which has diabetic retinopathy and you cannot decide that we need to refer it or not, it's better that you refer the patient. So if we follow that MTMDR criteria, this divided population, the number which is there, the 20% and the 30% population, this directly gets added to the correct answer population, and the positivity rate increases directly to 80 to 90%, therefore increasing the referral capabilities. So as I said before, in clear-cut cases, everyone knows what to do. In borderline cases, rather than considering vision-threatening diabetic retinopathy, we should consider more than mild diabetic retinopathy, and this would increase our positivity rate and would also increase the referral capacity of the ophthalmologists. So in current scenario, human analog can be considered a very important screening tool for diabetic retinopathy referral, and this would combat the load of diabetic blindness in our nation. This would also be very good opportunity for availability of prompt and affordable services in the remote parts of our nation. Thank you so much.
That sensitivity and specificity is even that the participant dependency also.
Yes,
So
yes.
when we are comparing 2020 to 2023, the participants should have been same. Only you can conclude. Otherwise, every time you go on changing the participant, an IQ level of participants will be different.
Yeah, that is there. That is there.